discuss about the treatment of anemia and myelofibrosis, and they will discuss together with questions and answer. So I don't want to lose time and invite Professor Martin Gresheimer to start his presentation on special lecture on anemia in myelofibrosis. Please, Martin.
Thank you very much, Francesco and Alessandro, and good afternoon to everybody. So my task is to talk about anemia in myelofibrosis, and I will touch upon the prognostic impact of myelofibrosis, anemia in myelofibrosis, about the pathogenesis, about the impact on survival, and I will give some data on the conservative treatment of anemia in myelofibrosis. So these are my disclosures, and we start with this slide about the key hallmarks and the clinical presentation of myelofibrosis, which is a classical triad of cytopenia, mostly anemia, and in some cases also thrombocytopenia, then constitutional symptoms, and last but not least, splenomegaly. And of course, we have the hallmark that is fibrosis. It is important to note that at diagnosis, nearly half of the patients are already anemic, with a hemoglobin below 10 in about 40%, and 1 out of 5 is already transfusion dependent. So finally, virtually all myelofibrotic patients will develop anemia at some point. And of course, anemia is associated with an inferior quality of life. Vice versa, if we can get a response to anemia by targeted therapy, then there is an improvement in quality of life and also prognosis. It is important to know that anemia is consistently associated with a poorer prognosis, and this becomes clear by the so-called prognostic scores, the DIPS and the DIPS Plus, that have implemented a hemoglobin below 10, but also the MySEC score for secondary myelofibrosis that has implemented the hemoglobin below 11 as a bad prognostic factor. So this slide illustrates the burden of anemia and also thrombocytopenia in myelofibrotic patients at the time of diagnosis. And as you can see, around 40% of all myelofibrotic patients have a hemoglobin below 10. 1 out of 4 has a transfusion requirement for erythrocytes, and a platelet count below 100 is found in 1 out of 5 patients. So after 1 year, the numbers are much more worse. More than half of the patients have an anemia with a hemoglobin below 10. Nearly half of the patients may be transfusion dependent, and 1 out of the patients have a platelet count below 100. So these are all numbers, but I think today the numbers are quite similar, already improving with modern therapies, and Professor Palandri will touch on the modern therapies. I will focus a bit on the pathogenesis of anemia and myelofibrosis, and this is a multifactorial thing, and there's no one cause. There are a lot of causes. Formerly, it was thought that fibrosis by itself and the displacement of erythropoiesis is a major cause of anemia and myelofibrosis. But this is only one cause. Another cause is exiled erythropoiesis migrating to the spleen and other extramedullary sites. And here, this exiled erythropoiesis is met with a suboptimal milieu for red blood cell genesis and maturation. And of course, splenomegaly prompts sequestration and destruction of blood cells, leading also to anemia. And finally, plasma volume increased with bleed size, leading to so-called phenomenon of dilutional anemia. But there are also some other causes. One important cause of anemia is that abnormal cytokine expression, which is very prevalent and important in myelofibrosis, promotes both local and systemic inflammation, and this inflammation causes decreased hematopoiesis and leading to anemia. And there's also a therapy effect, and I will touch on this later, that JAK inhibitors, ruxolitinib and fedratinib, are suppressing the hematopoiesis. And there are also other factors like autoimmune hemolysis or acute or chronic bleeding leading to anemia. And last but not least, the mutations have an influence on anemia. And for example, the calreticulin or MIPL driver mutations are less likely to develop anemia. So this slide illustrates the data on ruxolitinib from the pivotal COMFORT trials, COMFORT 1 and 2. And you see the grade 3 and 4 anemia in these COMFORT 1 and 2 patients treated with ruxolitinib. And these are quite impressive numbers, as you see that grade 3 anemia has been developed in nearly all of these patients. And grade 3 means a hemoglobin below 8, and grade 4, which has been found in more than 40% of patients in COMFORT 1 and 2, and is a hemoglobin below 6.5, has been found in 40%. So quite impressive numbers. So now we have really long-term data on ruxolitinib coming from the COMFORT trials and other trials and other experiences. And what can we say about ruxolitinib? Ruxolitinib is very effective in treating enlarged spleens, in managing symptoms, improving the quality of life. However, we have some key adverse events. These are infections, thrombocytopenia, but most prominent anemia. But it is important to know that anemia that is a consequence of ruxolitinib does not affect survival. So this is very important for the treatment. So anemia in myelofibrosis is associated with a lot of a variety of symptoms listed here on this slide. I won't go through this in detail, but for example, fatigue, which is already present in myelofibrosis by itself, is of course worsened by anemia. And the same applies to inactivity and a lot of other problems like mood disorders and so on and so forth. So the effect of anemia plays a significant burden on our myelofibrotic patients. In the first place, it's fatigue and tiredness, but also it is influential on the daily life with the ability to work and the productivity of our patients. And once they are transfusion dependent, there are other factors like iron overload and the time burden, that the time-consuming factor of these transfusions that is necessary for the treatment. But there's also anxiety still in many patients about safety issues like contaminations and infections. Last but not least, transfusion dependency means an increased economic burden. And this has been nicely shown by our American colleagues. You see in light blue the patients that are transfusion dependent, and in dark blue the patients that are transfusion independent. And by first glance, you see that the bar with the light blue, the transfusion dependent patients, is larger, meaning a higher economic burden concerning hospitalization, concerning emergency visits, concerning outpatient visits, concerning costs of treatment, including JAK inhibitor costs. So this is very important to know that in the end, it's also increasing the economic burden. But for the patient and for us as doctors, the prognostic influence of anemia in myelofibrosis is one of the most important issues, because this determines the fate of our patients. And as you can see here nicely on this slide, the degree of anemia goes along with prognosis. So for example, mild anemia has a median survival of 4 years, whereas severe anemia means a median survival of 2 years. Severe anemia is hemoglobin below 8. So in the end, the risk of death was increased by 50% in patients with severe transfusion-dependent anemia compared to moderate anemia, which is a hemoglobin above 8. So we have important and useful tools predicting the response to ruxolitinib, but also predicting survival in our myelofibrosis patients. And this so-called RR6 criteria, the response to ruxolitinib after 6 months, has been developed to predict the prognosis and the response to ruxolitinib. And as you can see, 3 factors predict the prognosis and survival in these patients. This is, of course, ruxolitinib dose. It is the potential of reduction of splenomegaly by ruxolitinib, but in the end, it's also transfusion dependency. And see here again, you see that transfusion dependency is one of the major determinants of failure of ruxolitinib treatment, and we have to early recognize this failure in order to go to second-line treatment. So as I said, I want to touch a little bit on the conventional treatments with not an impressive outcome of anemia treatment in myelofibrosis, but Francesca Palandri will touch on the modern treatments of anemia and the promising drugs. So it is important to know what the conventional results of anemia treatment was. So first of all, what can we expect by steroids? So the response is up to 50% in transfusion independent and less than 50% in transfusion dependent patients and more than 50% in transfusion independent patients. But the effect is only transient, and as you know, there are relevant side effects. What are the data in erythropoiesis stimulating agents? So the response varies from 40 to 60%. So there's a study, a Spanish study with 163 patients. There the response was 53%, and the response duration was around 90 months. There were some factors associated with a higher response, like female patients, a high blood count, and a low serum ferritin. But these effects were transient, also like in steroids. And it is important to know that the results are best obtained with a low serum erythropoietin, defined as lower than 125 units. So vice versa, with a very high EPO, it makes no sense to use EPO agents. So what we know about the danazol and androgens, the response rate is around 40%, including 44% of transfusion independent and 90% of transfusion dependent patients. So you see the same picture. If patients are already transfusion dependent, the numbers are, of course, lower. And this is important to know. The median time to response is 5 months, and the duration of response is a bit more than 1 year. So splenectomy, the response rates are, of course, higher in transfusion-independent patients, up to 60%, and lower in transfusion-dependent patients, up to 30%. But there is a high rate of perioperative morbidity, up to 30%, due to bleeding, thrombosis, infections, and post-splenectomy hepatomegaly. And there's also quite an impressive number of mortality with 9% respectively. And last but not least, what about the immune modulators, the IMiDs, thalidomide, lenalidomide, and pomalidomide? So there are varying numbers to anemia response, coming from 20% to maximum of 30%. We had in our POMing trial with pomalidomide. So not very impressive numbers, and with a restricted time of response also. Finally, I want to draw your attention to new definitions of transfusion dependency and anemia response. These are criteria that have been developed by the European Leukemia Net criteria for anemia response. These criteria are very important for trials, but also for the measurement of efficacy of our treatment. So I just want to draw your attention to the definition of transfusion dependency anemia. So there's the old definition from 2013 and the newer definition from 2025. where transfusion dependency anemia is defined as more than 3 units of blood in the 12 weeks before enrollment, and high transfusion burden means more than 6 units in the 12 weeks before enrollment. And down below you see the major response for transfusion-dependent anemia with a new definition, which is no transfusion in 12 weeks, and rolling 12 weeks average hemoglobin increase of more than 1.5 grams per deciliter from pre-treatment baseline. So I want to summarize the issue of anemia and myelofibrosis. So anemia is a key characteristic in MF patients, and finally every patient with MF will develop anemia. However, the underlying causes are not completely understood, and it's probably a multifactorial process. It is clear that anemia is associated with much more severe symptoms, not only fatigue, a lot of others also are determining the quality of life, the decreased quality of life. And finally, there is a reduced overall quality of life, but also bad prognosis and decreased survival. And reducing anemia should, of course, be considered, therefore, as an important goal of treatment in myelofibrosis treatment. With that, I thank you very much for your appreciated attention.
Thank you. You focused the most important point on anemia. And I just want to a high-risk disease, 1 out of 2 patients need transfusions, and intermediate 1 out of 4 patients. So as you said, this is the new clinical trial. And in your practice, when you have to manage a patient with myelofibrosis and anemia, do you prefer to use erythropoietin or danazol among conventional treatments? You know, I know that you have a lot of clinical trials, so we have not to consider clinical trial in this decision.
Yeah, thank you, Francesco. So we use EPO, but this is due to availability. So in fact, we have a problem to get the danazol. So this is the reason why we use the EPO. But I have another argument. There are some side effects in the older patients with the danazol, especially with the male patients having prostate problems, where we are reluctant or would be reluctant to use a danazol. But in the first place, in Germany, it's a point of availability. So it's much easier to get the EPO. So that's the reason why we use it.
Thank you so much. So now it is time for Professor Palandi. And Professor Palandi, the title for your presentation is Prognostic Impact of Anemia in Myelofibrosis. Please, Francesca, thank you for coming.
Thank you very much.
In this format, Professor Palandi will present some slides and then open the discussion between Professor Palandi and Professor Grace Hammer on some points. So this is a new format. So we ask you, Francesca, to be very, very smart.
Interactive. Thank you very much, Francesco. Thank you, Alessandro, for having me as a speaker, and good evening to everyone. So Martin has just explained very well what the pathogenetic mechanisms of anemia are and how they are so multifactorial and interconnected. What I will try to do now is to show you the link between these pathogenetic mechanisms and the development of anti-anemia drugs, which target these very mechanisms. And this is, I would say, quite a revolution, since up to now, the target drugs for myelofibrosis have specifically targeted the control of symptoms and of splenomegaly, but not specifically anemia. Particularly, we know that the hyperactivation of the activin receptor 1, ACVR1, and also the abnormal signaling of the TGF-beta pathway have been recognized to have a crucial role in the pathogenesis of anemia. And this is because both pathways are responsible for an increased hepcidin levels, which leads to iron metabolisms and unavailability of iron deposits for erythropoiesis. And as a consequence, there is a lower production of red blood cells and a lower levels of hemoglobin. So trying to make an orderly presentation, we will start with ACVR1 inhibitors, and particularly momelotinib and pacritinib. Momelotinib is like ruxolitinib, a JAK1 and a JAK2 inhibitor. So like ruxolitinib, this drug may improve constitutional symptoms, and this is mainly related to the inhibition on the JAK1 pathway, which leads to a decreased inflammation and a decreased production of pro-inflammatory cytokines. But also momelotinib may inhibit JAK2, which is the main responsible for extramedullary hematopoiesis and hyperproliferation. So through the inhibition of JAK2, momelotinib may decrease splenomegaly. Furthermore, momelotinib also targets ACVR1, and by inhibiting ACVR1, momelotinib is able to decrease hepcidin transcription, and this it may restore iron homeostasis and increase hemoglobin, leading to possibly an array of anemia benefits. Momelotinib has been approved by the FDA and by EMA, and is about to be currently available also in Italy, based on the results of 3 prospective clinical trials. The Simplify-1 trial was included patients treated with frontline momelotinib versus ruxolitinib. The Simplify-2 clinical trials included patients treated in second line after failure of ruxolitinib. And these patients were randomized to receive either momelotinib or BAT, including Rux. And finally, the Momentum trial included only patients with anemia, and these patients were randomized to receive either momelotinib or danazol, which was esteemed to be the standard of care for anemia at that time. So if we look at the results, we see that momelotinib has quite comparable spleen volume response rates compared to ruxolitinib in the Simplify-1 trial. It is non-inferior in the Simplify-2 trial, and it is clearly superior compared to danazol in the control of splenomegaly. The total symptom response at week 24 is slightly lower for momelotinib compared to ruxolitinib, both in the front line and in the second line. But momelotinib is highly superior compared to danazol in the control of symptoms. And finally, which is a very important clinical result, momelotinib use was associated with a significantly higher rates of patients with transfusion independency at week 24. If we look deeper in the Simplify-1 data, and we focus on the patient who started the treatment to ruxolitinib or momelotinib with a moderate to severe anemia, which means hemoglobin below 10 grams per deciliter, we observed that momelotinib and ruxolitinib had comparable spleen volume responses, so comparable efficacy in terms of spleen control. The percentage of patients achieving a total symptom score, a total symptom response was slightly lower with momelotinib. However, there was a significantly higher rates of transfusion independency for the patient treated with momelotinib. Also, if we try to catch a dual or triple efficacy in both drugs, we observe that spleen volume responses and transfusion independency is much higher with momelotinib compared to ruxolitinib. This is also true if we double the response of transfusion independency with the symptom response. And again, momelotinib has a higher response if we combine the 3 main responses: spleen responses, symptom responses, and transfusion independency. So overall, a very good efficacy profile. What happens to the hemoglobin when we treat a patient with momelotinib? As you may see from the graph, momelotinib is associated with a lower anemia compared to ruxolitinib in the first 24 weeks of treatment. And then we switch a patient from ruxolitinib to momelotinib, as we did in the Simplify-1 trial for patients with anemia. The switch to momelotinib resulted in an improvement of hemoglobin levels. Looking at the transfusion intensity in the patient who started momelotinib and ruxolitinib with a moderate or severe anemia, so hemoglobin again below 10 grams per deciliter, we observe that the percentage of patients with transfusion reduced or stable was significantly higher with momelotinib, 83%, compared to ruxolitinib, 42.6%. And what about the MOMENTUM trial, which was an important trial which focused specifically on patients with anemia and compared the results in terms of anemia response in the use of momelotinib compared to danazol? Well, if we look at the transfusion independence rate at week 24, we see that momelotinib is superior to danazol with 31% compared to 13% of to 20% of the patient achieving transfusion independence. And also the mean levels of hemoglobin are significantly higher with momelotinib compared to danazol. One other important piece of information came from the analysis of the simplified trials, where we observed that in JAK inhibitor-naive patients, so the patients included in the simplified 1 trial and were treated frontline with momelotinib, the condition of transfusion independence at week 24 was associated with a significantly improved overall survival compared to the patients who were not transfusion independent at that time point. And this information was the first proof that there is a kind of correlation between the achievement of a transfusion independence at week 24 and an improved overall survival. And differently, but similarly, we also observed that comparing the results of momelotinib in second line from the simplified 2 and the MOMENTUM trial and the data of overall survival that were provided by the ruxolitinib experienced MF cohort from Italy, we observed that the use of momelotinib after ruxolitinib failure was significantly associated with an improvement in overall survival for the patients who discontinued ruxolitinib while having an hemoglobin below 10 grams per deciliter. Coming to the second agent that specifically targets ACVR1, we must also discuss the results of pacritinib, which is a JAK2, FLT3, IRAK1, and ACVR1 inhibitor that received FDA approval only for the patients with a platelet count below 50. And if we look at the results of the PERSIST-1 trial frontline, pacritinib versus BAT excluding ruxolitinib, the PERSIST-2 trial, first or second line, the platelet count below 100, pacritinib versus BAT, including ruxolitinib, and PAC-203 trial in the second line setting, pacritinib 3 doses compared one each other. We observe that pacritinib has a meaningful spleen and symptom responses with around 20% of the patients achieving such responses. And these responses are particularly important for the patient with a platelet count below 50, which is a very frail population. But what is important is that 15 to 25% of these patients across the PERSIST and the PAC-203 trials achieved the transfusion independence from a transfusion dependency status at baseline. So again, the target of ACVR1 confirmed to have a clinical association with an improved hemoglobin levels. If we look deeper into the PERSIST-1 outcome, hematology outcomes in cytopenic patients, we observe that in the patients with anemia at baseline who did not receive transfusion on study, the levels of the median level of levels of hemoglobin were significantly higher for the patient receiving pacritinib compared to the patient receiving BAT. And for the patients who were transfusion dependent at baseline, a significantly greater proportion of these patients became transfusion independent with pacritinib compared to 0 in the BAT arm. Looking at the data of a PERSIST-2 trial, where 45% of the patients were JAK inhibitor exposed, 45% received ruxolitinib as BAT, and 45% of the patients had a platelet count less than 50%. As you see, around half of the patients treated with pacritinib achieved a reduction by at least 50% in the requirement of red blood cell transfusions, compared to only 9% in the BAT arm. And also the rate of transfusion independency at week 24 was 24% for pacritinib and only 5% for BAT. And please remember that in the BAT, erythroid support was included in, and mainly was represented by danazol, EPO, IMiDs, and corticosteroids. So before going to the second part of my presentation, if I may, if I may interrupt my presentation, can I ask, let me, okay. If I ask to have Martin join this conversation. Martin, I would like to have your opinion of these two new drugs, because these two drugs are not so experimental anymore. For example, momelotinib is available. There are already real life data coming up. So what is your opinion on our future use of this drug? Do you think that the focus is really shifting to the cytopenic patients? Do you think that we are going to select the JAK inhibitor also based on the cytopenic profile of the patients, both in the front line and in the second line?
Yeah, thank you, Francesca, for the talk up to now and for the question. So, the cytopenic MF patients, this has been an unmet medical need until the introduction of momelotinib and pacritinib. So we had no efficient treatments, and let us start with momelotinib. This is a completely new mechanism, as you nicely showed, with the ACVR inhibition, and the effects are impressive. We have seen this in the Simplify 1 and 2 trials. Unfortunately, it took a long time until we had the Momentum trial because of some issues we can discuss, but I don't want to discuss it now. But it took too long in my mind, because we already saw at that time that momelotinib is effective in treating anemia in myelofibrosis. And luckily, we had the Momentum trial, which had enough evidence that we got the license. And yes, we use it since we got the license here in Germany, and the effect is wonderful. So we see a dramatic improvement of anemia. However, we have already some side effects that are important. We see some effects on renal function. We see some effects, some side effects on peripheral neuropathy. However, these events are rare, and it's really a major improvement. And the same applies to pacritinib. However, we have a problem with the availability here in Germany, so we don't get the drug, which is really a pity, because below the platelet count of 50 and more, below 25,000 platelet counts, we have no drug. So we can use momelotinib within a platelet interval of 25 to 50,000. So there is some experience, but there's better experience for pacritinib. And as you have nicely shown, pacritinib is in this setting very effective. Of course, these are very frail patients, so the lower numbers of efficacy are well understood for the background that these patients are more frail. So to summarize it briefly, so a major step forward in the treatment of MF patients.
Yes, thank you. I totally agree. We also have problems in using pacritinib only in the Pacifica trial, so it's not available at this time. I just have one very short question, if I may. Would you use momelotinib or pacritinib for the patients with no splenomegaly or symptoms, just to target anemia?
That's not an easy question. So we are just renewing our German guidelines, and there we have introduced a new expression that is clinical relevant anemia. So we advise to give anemia targeting drugs, and this is in the first place momelotinib, only if there is clinical relevant anemia, whatever that is, because this is a definition of the treating doctor. So that means, in another sense, that if you have a hemoglobin of 9.5, and you think as a doctor it's not clinically relevant, it's not necessary to use momelotinib if you think probably Fedra or Rux is better. So this is how we solved it in Germany.
Yes, well, actually, I think this is an open question for everybody. So I just wanted to hear your first considerations. I think we're going to talk a lot about it in the future. So thank you very much. I'm sharing again my screen to continue the presentation now, if there are no other questions.
Francesca, can I ask you if you
Yes.
can summarize the criteria for the Pacifica trial, because the audience is
Sure.
coming from Italy. Martin very well discussed the point of...
Yes. The criteria for the Pacifica trial have been amended lots of times in order to make platelet count below 50, palpable splenomegaly, no prolonged ruxolitinib treatment before, or JAK inhibitor naive. These are the mains.
Excellent.
Okay, thank you.
Thank you so much.
All right. How can I? Okay, let's see what happens now. Let me share my screen again. Here we go. So let's have some insights on TGF-beta inhibitors. This is an extremely new class of drugs for myelofibrosis, and particularly we will focus on luspatercept, which is very well known, also because it is approved for MDS patients, and elritercept, which is a newborn in the panorama of myelofibrosis treatment. Okay. Luspatercept, as I said, is the first-in-class erythroid maturation agent. It binds several TGF-beta superfamily ligands, and in this way, luspatercept may diminish the SMAD signaling and enhance the late stage of erythropoiesis. The safety and efficacy of luspatercept in patients with anemia and myelofibrosis has been tested in a phase 2 multicenter open label study, which was published last year. The ACE536 MF001 study, including patients with or without transfusion dependency, receiving luspatercept in monotherapy or in combination with ruxolitinib. And what we have seen anemia responses across all the cohorts, but the greatest responses were seen in patients who received the combination with ruxolitinib. So luspatercept seems to be a very good partner for JAK inhibitors. And approximately half of transfusion-dependent patients receiving luspatercept achieved a 50% reduction in the transfusion burden. And this was confirmed with or without the association with ruxolitinib. Notably, most of the patients continued ruxolitinib at a stable dose. So it is really a good partner with no additional toxicity to the JAK2 inhibitor. We are now awaiting the results for the Independence phase 3 double-banded randomized study, which included the patients with anemia during JAK inhibitor therapy, and these patients were randomized to receive either luspatercept and best standard of care or placebo and best standard of care. And we are really waiting for these results in order to understand whether and when and in which cases luspatercept will become available for our clinical practice. Also, I think that a very promising agent is elritercept. Formerly, it was called CARE050. Elritercept is a TGF-beta inhibitor like luspatercept. It was specifically designed to inhibit the select TGF-beta superfamily ligands with a very broad activity on all the stages of erythropoiesis. Elritercept is currently under clinical investigation in the phase 2 RESTORE study, which results were presented at EHA 2024. This is a study which is now closed for enrollment. Included patients with MF and anemia, and these patients were randomized, could receive elritercept as a monotherapy again, or in combination with ruxolitinib at a stable dose for at least 8 weeks. What we have seen? We have seen that hemoglobin responses were observed both as a monotherapy and in combination of elritercept with ruxolitinib. We have also seen some good but initial reduction in the spleen size And the reduction in the splenomegaly was also observed when we used elritercept as a monotherapy. So this really supports that elritercept may have a role also to treat splenomegaly, particularly, of course, if we combine this drug with ruxolitinib, with around 15% of the patient achieving a reduction by at least 35% in the spleen volume by week 24. Also, which I think is very important for the patients, we observed some improvements across the symptoms domain, with around 1/3 of the participants that were available for the TSS response, achieving at least a 25% improvement in each individual item score at week 24. So elritercept may increase hemoglobin level, may decrease splenomegaly, and may decrease also the symptoms related to myelofibrosis. Finally, I would like just to spend a few words on hepcidin inhibitors because, and particularly on DISC-0974, which is an extremely new first-in-class monoclonal antibody that binds hemojuvelin and blocks the BMP-SMAD signaling. So this inhibition should result in reduction in the production of hepcidin, increased iron absorption, mobilization of stored iron into circulation, and finally, improvement in the hemoglobin levels. DISC-0974 was first tested in healthy volunteers, where this drug demonstrated to be able to increase the levels of hemoglobin and to decrease the levels of hepcidin over the time. But I think that last year at ASH, there was an extremely important presentation of a preliminary result of this phase 1b study of DISC-0974 in a patient with MF and anemia. Overall, 34 patients were included in this analysis. And as you may see, we observed the reduction in hepcidin, mobilization of iron, increased reticulocyte, hemoglobin, and improvement in the hemoglobin levels in these patients with myelofibrosis. Looking at the hematological response, we see that 68% of patients with non-transfusion dependency at baseline achieved a significant hemoglobin response in around 50%, by 50%. And 67% of these patients received concomitant JAK inhibitor therapy and achieved durable responses. If we look at transfusion dependent with a low requirement on transfusion, 100% of these patients had a reduction in the transfusion requirement. And also, if we look at the transfusion dependent with a high requirement for transfusion, 60% of these patients achieved at least a 50% reduction in their transfusion requirement. And 40% achieved the transfusion independency status by week 24. So I believe that these are important preliminary results that coupled with an overall good safety profile, with the most common adverse events being GI toxicity, particularly diarrhea, and headache in most of the patients. So I believe that this is, of course, a very new but promising new treatment that couples with TGF-beta inhibitors. And we really hope that these new drugs may increase our ability to target anemia and myelofibrosis alone or in combination with JAK2 inhibitors. Thank you very much. This was my last slide. I think we have time for some discussion.
Thank you, Francesca. So you have time to do some question to Martin again.
So I think that one burning question regards the role of transfusion independency and the survival expectation of our patient. Because if we know that achieving a transfusion independence really makes the difference in terms of prolonging the survival, then transfusion independency becomes the main target of our treatment. So we can forget about splenomegaly, forget about spleens, and just focus on transfusion independency. Do you think, Martin, that we have enough solid data to make such a statement? Do you think that transfusion independence is important, but not so much, or transfusion independence is the focus of our treatment now?
Yeah, well, I think it is, and you have nicely shown the data with momelotinib, but I think that's a general principle. So generally speaking, it's not so easy to define endpoints in myelofibrosis, but once you have a defined endpoint like transfusion dependency, I think it's both relevant and of prognostic significance once you get transfusion independency. So I think there is consistent evidence and clear evidence that this is an important endpoint, and once you get it, you will prolong survival. I'm quite convinced about that. The question I have is it really true also for not check inhibitor treatments? So to say it clearly, you have shown the data of the hepcidin inhibitors and the TGF-beta inhibitors, and if you use it in these drugs, so not check inhibition, is it also true? I don't know, because we had this discussion in Germany on the advent of the renewance of our guidelines. And our opinion, a bit in contrast to our American colleagues, is that just focusing on improving anemia by agents like EPO, or the same is true by hepcidin inhibitors, is probably not the same if you use a check inhibitor together with the other drugs. You know what I mean? So I'm not so convinced it's just focus on a not check inhibitor treatment. So let's say hepcidin inhibitor, we give the same prognostic impact. So I'm interested what your opinion
Yeah,
is.
well, this is an interesting comment. Actually, my personal opinion is that since myelofibrosis is a very complex disease, a multifaceted disease in terms of clinical manifestation, and in terms also of molecular genetics, biology, I believe that we must think of a complex treatment, which may target all the clinical manifestation and possibly the most profound biology of the disease. So I totally agree that it is not just a question of numbers, transfusion dependency, hemoglobin levels. It's a question to manage the disease properly. And possibly, I think that the combination of multiple mechanism of action, one mainly targeting the most splenomegaly, hyperproliferation, one other trying to sustain erythropoiesis, could be a great step forward in our management of myelofibrosis. So transfusion independence is, of course, very important. It is also important to achieve a spleen reduction, because we have nice data that the spleen volume control also correlates with an improved survival. So I think we do not make the same mistake that we had at the very beginning, when we thought that anemia was not important at all. And that was why, that was because we had no good treatment for anemia. So we just focused on splenomegaly and symptoms. I think that we have now the possibility to integrate more aspects of the disease and to target all of them. And that should be our goal.
If I can say something, just I think that the only answer to the question of Martin is stem cell transplantation for the time being, but stem cell transplant is on the unit 2, so we cannot discuss now about stem cell transplant. And Alessandro, please.
Yeah, thanks, Francesco. I'd like to try to translate the question that Martin did in another way, practical way. So we know that anemia is one of the most powerful components of prognostic systems, the DIPS, the MIPS, and so on. So the question is, if you are able to improve anemia with one of these agents, and you calculate again the DIPS or the MIPS, do you think that having improvement of anemia maintains the powerful of this course in terms of prognosis? That is something that also links your questions to the issue just raised by Francesco about the positioning of transplantation even in these patients. In other way, can we go back in the scoring system by inputting in the system the improvement of anemia?
Yeah, I think so. I think so. Yeah, sorry for rushing in. Yeah, I completely agree. So I think improving anemia is one step. But the question is, if you add, for example, a JAK inhibitor to this treatment, the effect is I think greater. And once you start the treatment, why not starting all? That's my point.
Well, one of our consideration is that we calculate the score in order to make the transplant trajectory. And if we have, for example, a resolution of constitutional symptoms, so my patients shift from an intermediate 2 to an intermediate 1 patients, we generally educate our colleagues to stay on the transplant trajectory, not to think of the improvement that we had with the JAK2 inhibitor alone, but to keep on with our project on transplantation. I'm not that sure that we have data enough to switch our way of thinking in terms of transplantation if we get important results during treatment. I don't know. I'm very interested also in listening to Professor Vanucchi's opinion on this question.
Well, I think that the answer is probably in what Martin was saying before, that if you improve anemia, this is a general reasoning, with agents that do not target the clone, that may be EPO, may be one of these latest agents, you actually don't change the course of the disease. So provided that you have drugs that combine the activity on the clone and improvement of anemia. For example, Francesca, you touched drugs specifically under development for anemia, but there are also preliminary data for combinations, for example, a JAK inhibitor and a BET inhibitor, where you may have also improvement of anemia, and you might have evidence of also of targeting the disease. So to me, the answer is when you have an efficient drug against the disease, against the clone, you can show reduction of the mutation burden and so on, and you have improvement of anemia. That is something that may actually tell us that anemia is improved and survival is improved. If you get improvement of anemia with ritercept, with danazol, with erythropoietin, probably no, you have benefit for the patients, you reduce the transfusional burden and so on, but I'm guessing whether the improvement in the score means that you have to stop the path to stem cell transplantation.
So, Alessandro, do you foresee a better indication for this anti-anemic agent, for instance, just for older patients with myelofibrosis and anemia?
Well, again, targeting anemia to me is a very important target for the disease control, because it improves the quality of life of the patients, it reduces transfusion, the burden on the health system, and it prolongs survival. But if you have a young person where, according to the scores, you have indication for transplantation, to me, improvement of anemia with the agents that we currently have should not change your mind in terms of going to transplant. We have some evidence also about the timing to go to transplant. And at present, I would not change my mind about that.
I fully agree with you. I think this is an important message. So now that it's time for message, Alessandro.
Yeah. So we are at the end of this session. I would really thank Martin and Francesca for their presentation, very updated, very topic closed, because we have discussed about the pathogenesis, the prognostic impact, and also gave a look about more modern treatments for anemia. So I enjoyed the discussion. I'd like to thank also Francesco for co-chairing and introducing and managing this session. And I think that we can just give an appointment for the second 50 minutes on myelofibrosis. Thank you for being with us, and thank you for all my colleagues.
Thank you, Alessandro. Thank you.
Thank you.
Thank you very much.
Thank you. Bye.
Non siamo più collegati?
Abbiamo concluso il webinar, grazie a tutti.
Perfetto.
E arrivederci alla prossima.
Direi molto
Grazie.
bene, no?
Perfetto.
Ottimo, perfetto.
Grazie mille a tutti,
Grazie,
buona
arrivederci.
serata.
Ciao Francesco.
Ciao, ciao.